folks to come in now, so it'll just be a few minutes.
No problem.
Doing good?
Yes.
Okay, good.
These
Are you guys fine in that order, or do you want to sit in the order that you're speaking? Okay.
Wherever you'd like me to. Where would you like me to go?
On my lap.
Really?
You're on my lap.
Okay, there.
good here. You can hold our hands.
Sandeep, is it? Are we going to be able to see our slides on that computer while they're? Okay,
Yes.
perfect. Thank you.
And there's a clicker, and if you'd rather do the computer, whatever you prefer.
Thank you.
No problem. Okay, so the order again, so I recall was
How come everyone has a black pen?
Mary
What is
Daniela,
that?
right? Is that what we said?
I'm last. That's all I
Yeah, I
remember.
remembered that.
I remember that I'm last. I think I know.
I have a pen.
Janet
Don't
and-
worry. Don't worry about me. Sometimes don't listen to me.
Okay, yes,
You're both like
She's
the
gonna have
framing.
of course. Yeah, and I will too, so I just want to be able to.
May I borrow your book for a few minutes?
Okay. So we're encouraging folks to come in now, so we should start anytime.
Oh, another important question.
You don't want to broadcast it?
Is the camera only on the person who's speaking? Or is
No,
it
it's on the panel during. No, it depends. They go in and out. But during the Q&A, it's usually on the whole panel.
okay. Yeah, that's exactly. Yeah. Don't like pick your teeth or something. Like. Exactly.
Yeah, it's funny. Oh, the things we have to think about, like sometimes people might, and then they'll try to go to the bathroom, and I'm like,
Oh yeah. Bad idea.
so.
You might regret that.
Some like indication that we were like gonna want me to talk to like the press people after this panel.
Oh, that's right. I forgot about that.
Yeah,
She
let's-
did say something about that.
Yeah, let's ask if that's gonna happen or not
Yeah.
because people were asking sticking around or not.
Yeah. Right up here.
Yeah. This is a weird room. I think it's
It's funny because it's so dark.
so dark. I know. I feel like
I'm jet lagged, so I started to feel like a little bit confused about what time of day it was. Yeah. It's at nighttime. Yeah. And my body clock was all thrown off in this dark room.
I've never been here before. I don't know if they have other spaces, but
Yeah, I've never been to the center. It looks like a beautiful space.
yeah.
And I didn't realize we'd only had one president with a PhD. I guess I never really thought about it before. Yeah.
Let's ask Tamil that question.
No. So that is being canceled. So I don't think that there's any press here, but if they are, they can come and talk to us afterwards. If not, we don't have to do that. I'm sorry, I meant to send an email.
Oh no,
So
it's
you're up
okay.
at the
No,
podium, right?
Um,
You're talking up at the podium?
Yeah.
the large bureaucracy process that you need to go through as president.
It's Janet and then you.
Made
And then
it
Tamil and then
Yeah,
Yana.
even though we were going to do something more informal, they wound up.
And I'll wave when you have it.
It's just another whole thing to coordinate for you, I'm sure. So.
Are you set?
On top of. Oh.
All right, so why don't we go ahead and get started again? For those of you who weren't here the first half, today's program is entitled Maternal Health and HIV, Global Priorities for research and action. My name is Sandeep Pathala. I'm a Senior Program Associate with the Global Health Initiative here at the Woodrow Wilson Center. Today's event is brought to you as part of the Global Health Initiative's Advancing Dialogue on Maternal Health series, where we look at many critical and neglected maternal health issues. And our work is generously supported by the Maternal Health Task Force as well as the United Nations Population Fund. As many of you know, especially because you come to other events and because you heard me say this exactly 2 hours ago, the Wilson Center is a formal memorial to our 28th president, the only president thus far to have achieved a PhD. So in his honor, we aim to bring the worlds of policy, practice, and academia together to better inform one another. A note about today's meeting, we are being live webcasted. So what that means when we come to the discussion portion for those in the room, we'd ask that you use a mic and introduce yourself and affiliation. And I will have colleagues walking around with mics when we do get to the discussion. You have bios in front of you, so I wanted to direct your attention now to a privilege that we have today to have Kathleen McDonald from the Maternal Health Task Force moderating today's event. She leads the Respectful Maternity Care Programs for Women in Health Initiative at Harvard School of Public Health. So very appropriate person to be helping with the moderation of this panel on addressing stigma and preventing disrespect and abuse, global insights to improve maternal health and promote reproductive rights. Thank you. And one last note, we are, if you're interested in tweeting the hashtag, it's up here, it's MH Dialogue, and if you are tuning in and you have any questions, feel free to ask them via Twitter.
Thank you, Sandeep. Good afternoon. Today we have the opportunity to discuss HIV-related stigma within the greater context of respectful maternity care. Respectful maternity care is an agenda that I just want to note has seen a resurgence in recent years due to many of the people who are in this room, particularly USAID. Our esteemed panelists today will focus on discrimination and abuse that women face globally, not just within their households and communities, but also at the hands of their healthcare providers, a profession whose ethos is first do no harm. As mentioned, the theme of today's panel is reproductive rights. During the presentations today, I encourage the audience, both here and online, to consider reproductive rights and the quality of women's health services. Are these constructs mutually exclusive? Or does one not exist without the other? We'll have time for question and answer at the end of all of the speakers speaking today. And just if you're following along online, please join the conversation with the hashtag MHDialogue on Twitter. So without further ado, I'd like to introduce Janet.
Hello, I'm very pleased to be here to present some of the work that we've been doing on looking at how stigma and discrimination serve as barriers to achieving global PMTCT and maternal health goals. And a lot of this work I've done together with my colleague, Dr. Laura Nyberlade, who's in the room, of the Health Policy Project. So I think those of us who were here this morning, we heard a lot about some of the potential pathways how HIV can adversely affect maternal health. And we talked some about some of the biological pathways, increases in HIV-related infections, including TB and malaria, of course, the effects of advancing HIV disease, and then elevated pregnancy and birth complications among HIV-infected women. But what we're going to focus on today in this panel is more thinking about how HIV-related stigma and discrimination might affect both utilization and the quality of essential maternity services. And as you can imagine, these effects can affect all women who use these services, as well as especially HIV-infected women. So stigma is of course a term that's thrown around a lot. We hear it all the time, and those of you who've maybe been studying it know that it was most famously introduced by the sociologist Irving Goffman back in the 60s in his work on Notes of the Management of a Spoiled Identity. And there are a lot of course, more formal definitions, but in general, we can think of it as a social process in which individuals with certain attributes or behaviors lose social value. And there are a lot of health conditions that, of course, we all know that have stigma and discrimination associated with them. HIV and AIDS is maybe the most famous case, but there's also stigma around tuberculosis, around obesity, around mental illness, around substance use disorders, and the list can go on. Now, the field of studying stigma and trying to understand and prevent and mitigate its effects has been around for a while, and there are a lot of different sort of dimensions or types of stigma that people talk about. And one of them is anticipated stigma. So that's when they fear stigma, discrimination, and negative reactions if other people would find out that they have the condition. There are also perceptions of community norms. What do people see happening out in their communities to people who are living with HIV or other issues? Then there's the actual acts of discrimination and abuse that do occur, and this can be called experienced stigma, enacted stigma, and even sometimes just observing that kind of stigma has effects on people. Another really important aspect is internalized stigma or self-stigma, and that's when people actually internalize some of those negative attitudes and feel that they are a bad person because they are in this group. Now, pregnant and childbearing women who are HIV infected are especially vulnerable to some of these effects. As we know, in a lot of the countries that we're talking about in Sub-Saharan Africa, the pregnant woman is often the very first person in the family to be tested for HIV because of her contact with the antenatal care clinic. So she gets blamed for bringing the virus into the family. In many countries, there are gender norms, of course, that overly penalize women for promiscuity, which is often associated with HIV. And there are negative judgments about HIV-positive women having babies and the real issue of risk to the unborn or the newborn child. As we talked about this morning, if HIV-infected women are asked to follow different infant feeding practices than other women in the community, then that can cause unwanted disclosure. And then there's just the whole issue of socioeconomic vulnerability of these women. And so this is starting to come to the notice of the world, and even in New York Times had an article on stigma of HIV as a barrier to prenatal care. And so some of the results that I'm going to present today are from a strategic review that we conducted to try to look at what are the effects of stigma and discrimination at each step of the complex cascade of services that women have to complete, women and infants need to complete in order to prevent mother-to-child transmission and preserve maternal health, and which is usually known as the PMTCT cascade. And this has been presented in a working paper, which copies are available outside on the door, and we also did a subsequent journal article in AIDS and Behavior that people can access. So sometimes people, we need to sort of conceptualize, okay, we know stigma and discrimination are bad, but what are the pathways through which it could actually affect maternal, neonatal, and child health? And so stigma and discrimination, both anticipated or experienced or internalized, have very known psychosocial effects. Shame, guilt, fear, negative attitudes. And these kind of psychosocial effects can have both direct effects on mental health and other aspects of health, but then they also have often some behavioral consequences that people who perceive these things don't want to disclose their status to other people, may avoid essential maternity and HIV services, maybe don't want to take their medications if other people are going to be around to see them. And so then it's pretty clear that you can see how these could have real effects on a variety of health outcomes. Now, in our review, we sort of highlighted some of the different types of stigma and discrimination experienced by pregnant women around the globe. And we reviewed both qualitative and quantitative studies. So in terms of anticipated stigma, here's a quote from a focus group participant in Soweto. I didn't book at an antenatal clinic because I was afraid that they would test me for HIV. So I avoided it as I told myself I might be found to have this disease. There's a clear example. Perceived community stigma. So this was from a PMTCT program in Malawi where they found that half of their participants dropped out before completing the program. And the main reasons that were given by participants were fears of unwanted disclosure and negative community reactions. Self-stigma was identified in a study in India where HIV-positive women who were mothers judged themselves negatively, feeling that somehow they were not able to be good mothers or, or properly care for their children because they had HIV. And then here's an example from Mexico of some very clear enacted stigma, and again from health workers, as was mentioned, as was maybe one of the more damaging types of experiences. A young woman gave her experiences. The doctor said, "How can you even think about getting pregnant, knowing that you will kill your child because you're positive? He threatened not to see me again if I got pregnant. He told me I was irresponsible, a bad mother, and that I was certainly running around infecting other people." That's pretty blatant. Now, another issue that I'm sure many people in this room are aware, that many women living with HIV are not just dealing with HIV-related stigma. They are dealing with stigma from a variety of different identities that they may have. So a poor woman in a marginalized racial or ethnic group living with HIV might be dealing with stigma because she's poor, stigma because she's in that racial or ethnic group, stigma because she's living with HIV, and then being pregnant with HIV on top of that. Now, this is the PMTCT cascade that I'm sure many of you are familiar with, that are representing all the steps that mothers and infants would have to complete to successfully prevent mother-to-child transmission and protect maternal health. And it's also well known that at each step along this cascade, we're losing women and infants. Women are dropping out, not completing each step. And some of this is somewhat improved by the option B+ strategies, where at least we take out the step of CD4 testing and waiting for CD4 results, but there's still a complicated list of services. And so I'm not going to be able to give the full results of the review here today. Just to summarize, we really found a wealth of qualitative data and some quantitative studies that quantify the effects of stigma on PMTCT and maternal health. And we found that the negative effects of stigma and discrimination really start in the very beginning with women's initial use of antenatal care services, but they continue on during pregnancy and postpartum through that entire period. And there have been modeling studies that have been conducted showing that the effects of stigma and discrimination at each of these steps are cumulative and likely to have a huge effect on rates. So we concluded that it's unlikely that these major global commitments to eliminating new child HIV infections and reducing HIV-related maternal mortality are going to be achieved if we don't make major efforts to identify and counter HIV-related stigma. And the good news is that there are quite a few, evidence-based stigma reduction tools and interventions, as well as measurement tools to evaluate progress. And we just need to modify those for the special needs of pregnant women and their partners and test them and get them out there. And we really feel that this is a really essential piece of providing care for all women, men, and children. Now, what I'd like to now just very briefly is highlight some results from some of the work that we've done in Kenya over the past, 5 years or so. The MAMA study was an NIMH-funded study where we investigated the relationships between women's experiences and perceptions of stigma and their use of HIV and maternity services in Nyanza province, Kenya, for those of you that know Kenya. And so just to summarize some of the results, as I think Tamil already mentioned, that we found a significant effect of anticipated stigma in that women who anticipated stigma from their male partner at baseline before they were offered testing were 2 times more likely to refuse HIV testing than were women who did not anticipate that kind of stigma, even after adjusting for a lot of other variables. We also have looked at use of essential maternity services after that initial antenatal care visit. So we know that women's fears about lack of confidentiality, unwanted disclosure, and stigma may cause them to avoid these services for pregnancy and childbirth. And in Mamas, what we found, and this is among actually all women, not just HIV-infected women, we found that women who had higher perceptions of HIV-related stigma at baseline were subsequently much less likely to deliver their babies in a healthcare facility. And again, adjusting for a lot of other predictors of health facility birth. Now, we've talked some today about lack of disclosure, and disclosure is a difficult and a sensitive issue, and we really have to respect women's rights and decisions in this area. But it's clear that, when women fear and experience stigma and discrimination, they're going to be less likely to disclose to others. And this is potentially a key pathway for these effects of stigma that we're seeing. And so for the HIV positive women who were in the Mamas longitudinal cohort, we found, so these women were tested in pregnancy and we followed them until about 6 weeks after the birth. And we found that only 58% had disclosed their HIV status to anyone, and only 31% had disclosed to their male partner. So they found out they were positive quite a while ago. And we also, our data show that, again, that this disclosure is very much related to whether they feared or anticipated stigma from their male partner. Now, we've since been looking at this disclosure issue a little more closely, and we found some very kind of striking findings having to do with disclosure and use of basic maternity services. And I'm going to focus just a little bit on the facility birth finding because it's quite striking. So when we broke women down by their HIV status and if they're positive, whether they had disclosed or not. And you can see for HIV negative women that around 35% of those women delivered their baby in a health facility with a skilled attendant. And that's about the average for rural Nyanza province. But then for the HIV positive women, when we look at the ones who had disclosed their status to someone, 48% had delivered in a health facility, much higher than the average for the province. But for those HIV positive women who had not disclosed to anyone, only 15% delivered in a health facility. And there's a similar trend for having 4 or more ANC visits. But again, the striking thing is that those women who have not been able to disclose to anyone having much lower rates of adequate antenatal care. So, and again, we are doing multivariate analyses that we're getting ready to publish these, and again, these relationships do hold up. And Dr. Sydney Spangler is in the room who's leading that paper. So what can we do? And I think maybe I won't go into too much detail on this. This is taken from the Maternal Health and HIV Policy Brief and some of the recommendations that are specifically in this area. It's clear that we need to address and mitigate these social factors which are contributing to poor maternal health outcomes and are barriers to treatment and care. We need to promote social support for pregnant and postpartum women and mobilize communities. And so for those of us who are researchers, there's some recommendations to improve the evidence base. We need to evaluate the effects of these stigma reduction, violence reduction types of interventions on maternal outcomes. And we need to test some of these interventions that are trying to, transform the social environment to see if they really do support women's use of HIV and MCH services. And so I have 2 upcoming studies that are planned in rural Kenya, which I think are going to address some of these issues. We are going to be testing a home-based couples intervention that's aimed to increase couple HIV counseling and testing, safe disclosure, and family health in rural Kenya. This is an intervention for pregnant women and male partners, both HIV positive and HIV negative, because the issue of keeping women who are initially tested negative is also a really important one. And we have another study where we're going to be testing 2 different interventions that are going to help women, we hope will help pregnant women living with HIV with medication adherence and retention in HIV care. And those interventions are community-based mentor mothers, so similar to the Mentor Mothers program that we've talked about already, but more integrated into the community. And again, taking advantage of mobile phone technology, text messaging intervention. So I think I'll stop there, and I just want to acknowledge everyone who has contributed to these studies and the research, including all of our co-investigators in Kenya and in the US, and NIMH and USAID funding for the strategic review. Thank you.
Excuse me. Thank you very much, Janet. Up next, we have Dr. Mary Monica Sando from Management and Development for Health.
Good afternoon, everyone. On behalf of my team back in Dar es Salaam, Tanzania, and our colleagues, collaborators at Harvard School of Public Health, Women and Health Initiative, I'm happy to share with you some of the work that we have begun to do with a clear focus of trying to promote respectful and dignified healthcare in Tanzania. So disrespect and abuse during childbirth is indeed not a new phenomenon, but received a lot of attention in 2010 after a USAID commissioned landscape analysis, which reviewed the definition, the scope, contributors, and impact of disrespect and abuse. They looked at the promising interventions and gaps in the evidence, and from that, identified 7 common themes of disrespect and abuse in childbirth globally. And I will touch on each of these briefly, and just to summarize, for example, with physical abuse is when a woman during labor is pinched or slapped by a healthcare provider and in an essence of helping her deliver safely. But also non-confidential care is when there is lack of privacy. A woman could be examined, in public, and or is laboring in public as well as if there is patient information being discussed in public as well. When we talk about non-dignified care, here we have usually intentional humiliation. There's rough treatment, women are scolded at, they're mocked, called names. These are examples of such incidences that fall into the non-dignified care. And in discrimination, usually it's related to specific, should I say, patient attributes. We've mentioned quite a lot from the previous panel on an example of a woman being HIV positive and that being a reason for her to be discriminated, but also age, as well as people who belong to different socioeconomic status and background. All those could be grouped into different reasons for why women are discriminated. But also detention. When women deliver, especially in facilities where they're expected to pay for the service, her and her baby would be detained in the facility unless they pay and would not be discharged to go home. Abandonment has also been reported commonly, and in this case, usually during the actual process where a mother is about to give birth or in the time that she's about to deliver, healthcare providers would ignore her and fail to provide the care, monitor her, and possibly intervene as required, and she would labor and sometimes deliver on her own. So from these examples, after the grouping of the different themes, we see that disrespect and abuse in childbirth is not just a quality issue, hindering the delivery of skilled care during childbirth, but also it is a great cause of suffering to women. And most importantly, it is a violation of women's human rights. So we'll look at the barriers which are very familiar to most of us, if not all, to why women do not get to a healthcare facility for delivery. And as we know from the MDGs, one of the key strategies towards reducing maternal morbidities and mortalities is to ensure that women receive skilled delivery assistance. And so looking at this model, we also see that, if I can briefly describe, it is grouped into three. There is a delay in the decision within the home, either from the woman or her family, to seek the care that she needs for her to have her delivery at a health facility. And the second delay is in being able to reach the healthcare facility. And the third is actually upon reaching the healthcare facility is the delay in receiving the actual care that the woman requires. Again, disrespect and abuse affects all these three areas. And if I can cite some simple examples, with the delay in seeking care, if providers do not adhere to cultural norms and they act in a non-dignified manner or discriminate women or affect women in any of the 7 themes of disrespect and abuse, women are least likely to opt or choose to go and deliver at that particular facility. And so this is very common, as seen in countries like Ethiopia. So when it comes down to the fact that the woman did not have an actual plan to go and deliver at a healthcare facility, in an event of an emergency, now that she needs to be seen and delivered at a healthcare facility and there is no plan in place, this causes further delay in an emergency situation, further complicating her situation of a good birth outcome. And in the third delay, upon reaching the healthcare facility, disrespect and abuse, a woman is actually prone to any of the disrespect and abuse themes. And for example, here, if she gets into a facility that is extremely overcrowded, she is likely to be affected by being abandoned. The healthcare providers are few. She comes in, she's in an emergency, or even if it is just within a normal state that she requires service, but there are few healthcare providers, she can be left at the corner and end up delivering by herself. Now, I would just like to touch a little bit upon our maternal health indicators in Tanzania, since I'm going to be sharing some results, the baseline results of the study that we have done. And we're among countries that still have a high maternal mortality rate, recorded at recently 2010-11, 454,000 per live birth, and we still have quite a high total fertility rate, where an average a woman of reproductive health has about 5 or more children in her entire life. But also, with this, having about 2 million pregnancies recorded per year, half of them delivering away from the facility, mostly by traditional birth attendants, we still are also continuing to have the high risk as to the reasons why we have high maternal mortality rate. But also when we look at Dar es Salaam, our nation's capital, the situation is different. More than 90%, actually sometimes it's recorded at 98% women deliver at healthcare facilities. But the challenge we see here is that even though facility delivery may be high in Dar es Salaam overall, but disrespect and abuse may negatively impact the health outcomes, where the region has among the highest maternal mortality rates in the country. So this is just a snapshot of just a year or two ago of one of the big healthcare facilities where we're actually doing the intervention project that we've done the baseline and planning to do interventions soon. At this facility, this is just a simple example, and as I had mentioned, the abandonment. Imagine a woman coming in labor and walking into such a room. She's really prone to, she's already seen, she comes in, there are women who've been there before her. She might be next in line, who knows when she would be seen. So this is roughly the way it was. This facility usually used to have about 2 providers working per shift, and so we're talking about mainly 2 midwives every 8 hours in a 24-hour shift. And they would deliver 80 deliveries per day, making about 2,000 plus deliveries a year. And it is among facilities that have and have continued having a high maternal mortality rate. On average, a death, one woman would die per week. So this is just a simple example as to why interventions like the one we're trying to do are extremely important in situations where the facilities are extremely overcrowded, the staffing is extremely scarce, and at the same time you want to be able to come up with interventions that can help salvage the situation even though the reality is extremely difficult. And so just to touch on transitioning into the Uzazi Bora project, its main aim is really to contribute towards our national goal in improving maternal and child health services by implementing locally tested interventions to reduce disrespect and abuse during childbirth, but also again to highlight the USAID landscape analysis. Despite the extensive documentation of many assessments, there has been noted that there was a lack of prevalence estimate of abuse or disrespect in facility-based delivery. And so this project's main three aims were to determine the types and prevalence of disrespect and abuse, to be able to gain an understanding of factors that contribute to disrespect and abuse, but also at the end be able to design acceptable, effective, and sustainable interventions to reduce disrespect and abuse during childbirth. And today I will share with you a brief overview of the types of disrespect and abuse, as well as the prevalence that we're seeing, and some of the insights from the bivariate and multivariate analysis of the experiences that we have noted so far. The baseline assessment of this study used 5 different data collection methods, and the tools were generously borrowed from the Population Council as well as the AMDD. What we did was structured interviews, and in this the focus was to assess healthcare providers' knowledge of respectful care practices as well as their job satisfaction and stress issues. We also in this did an observation of client-provider interactions during labor and delivery to objectively document instances of disrespect and abusive behavior. Exit interviews were also conducted to 2,000 postpartum women, and in this case, to be able to document any self-reported instances of disrespect and abuse. We also did a subset of community follow-up of about 70 women to be able to reassess self-reports on disrespect and abusive behavior, and to further gain an in-depth understanding of systematic, facility, and job-related driving factors of disrespect and abuse. In-depth interviews were performed with key informants. So just in summary, to highlight the overall quantitative findings that we saw from our baseline assessment, as you can see, overall in the community follow-up, we saw a much higher reported incidents where women reported having experienced some form of disrespect and abuse by about 77%. If you look at the exit interview immediately post 2 to 3 hours post delivery prior to discharge, it was about 15%. So looking at this and highlighting the mostly reported were physical abuse, as you can see, non-dignified care as well as abandonment. One question that comes when you look at such, a summary is with abandonment, and when we look and when we try to focus on universal access and coverage of healthcare for all, if 50% of women reported having experienced some form of abandonment during an actual time where they were so vulnerable, they needed a healthcare provider to help them as they're about to deliver their child. Where are we going, with all this? It's important that it's looked at as we look into improving the health system overall, while we focus on health access for all. But then when we see the difference between the two, can we tell, even though the exit interview was an actual representative and powered sample to give us the prevalence of the disrespect and abuse we've seen, the community follow-up was rather not powered. But if we were to look at this and re-examine, say, power a sample enough and go out into the community, would we be likely to get results that would tell us that the problem is actually even more than what we're reporting statistically from just the exit interviews? So these are some of the questions. Maybe we are underreporting. Maybe the problem is bigger than what we've even seen just from the exit interviews. So I'll just, for the interest of time, summarize on physical abuse as well as non-dignified care, even though we do have an extensive summary of all the results from the different themes of disrespect and abuse. So with the physical abuse, again, we see a much higher report with physical abuse when women have gone home 4 to 6 weeks later and they were followed up and interviewed using the same tools by the interviewers, where about 51% reported, again, some form of physical abuse during childbirth. And of course, slapping was much more commonly reported compared to the rest. So when we look at this, and if you look at the results, let's say for episiotomy, you wonder if women received an episiotomy without anesthesia, is that, the question that can come to mind is that because, is that considered disrespect and abuse? Or it's because it's the practice and it's what's expected and women do not know that they actually do have a right to have an anesthesia while they're receiving an episiotomy? So these are the issues. How much is the awareness out there? And when we go out and tackle issues of disrespect and abuse, how much do we need to ensure we also invest in educating women to understand their health rights and not as a human rights issue as well? With non-dignified care, we saw also exactly the same, higher reports of having experienced some form of non-dignified care more in the community follow-up compared to the exit interviews that were done. So here again, when we look, the higher incidences reported where a woman being shouted or scolded at, and this is again when I mentioned the prior three, the 3 delays model, the initial one where a woman hesitates or takes time to make the decision to seek care from the very beginning. If I was scolded and shouted at, and I'm now carrying my second pregnancy, am I really likely to go back to the same facility, or leave alone to even go into a healthcare facility? But if my neighbor was treated by a traditional birth attendant and had an excellent experience, I might choose that option, not to go into any facility or to be seen by a traditional birth attendant. So we saw this commonly and similar to some other studies. So again, a question that we could pose here is, when women do not know that they have a right, there is one report of women being called by, using their name, when they do not know that they have a right to be called by their name or to be treated and welcomed in kind. So we wonder whether we can term that disrespect and abuse, or it's something that mothers expect, to just be called a client. Can you move over, providers not introducing themselves, etc. So these are the issues. Now, I would like to borrow a phrase from my mentor's mentor, that what I just presented are just really statistics. And statistics are just people without tears. And I like that very much. So I thought we share with you the souls behind those statistics. And in these, I would like to quickly highlight that the women's voices are what women reported from what they experienced. And the observer behavior is what, as I mentioned, we did observe about 200 women. It's what it's reported by the third party. This is what the nurse who was observing the woman receiving care saw and documented. So the women voices, one is, I called the nurse when the baby was slowly descending, and yet when she came, she hit me with her fist on my thighs and slapped me. To be left nude, everyone passing seeing you naked. That's another respondent. I called the providers and she told me she was drinking tea and I should not disturb her. That's another respondent. On the other hand, the observers noted that at some point women, the observers noted the following: "You feel good delivering on the floor. Don't you see you're making me tired?" So this is a provider responding to a woman, as was observed. Another one was, she was told by the nurse that the nurse doesn't want noise and to be disturbed. She called the nurse for help. The nurse replied in ridicule, "Wait till God comes to help you." And next we get to hear the voices from the providers themselves. This is what the providers reported. "You may find delivery beds are empty, but the mother is pushing the baby on the floor and wants to deliver the baby on the floor. And when you try to tell her, don't deliver from the floor, go there where it is more clean, she will say that you're abusing her, while in actual sense, you're saving both her life and the life of her baby by ensuring they don't get any infections." This is reported by a provider. There is need to scare and threaten mothers in delivery since they fail to cooperate. Another provider reporting stress, job stress and burnout. Sometimes anger and tiredness due to work lead us to such things. Sometimes mothers dying in the ward. We can be busy in such a way that we don't even see or talk to each other. You find, like, for instance, a mother is in a stage of dying and you're all running around trying all you can to save her. Another mother comes and says something like, "Where is my card? I want to be discharged." For sure, you can expect harsh responses from providers. Basically, what I'm saying is what I'm saying here is that based on the way we're too busy, any patient who comes to ask some unnecessary questions, we end up responding harshly. So just to conclude and in summary, disrespect and abuse is a problem in Tanzania, just like it is in any other part of the world. Disrespect and abuse is a complex issue influenced by individual, community norms, provider, facility environment, and system factors. Addressing disrespect and abuse will be difficult and complicated. The project that we are doing will focus on interventions that target patients and providers within healthcare facilities. Thank you very much, and I would like to acknowledge our participants and collaborators in the project.
Thank you very much, Mary. Next, we have Tamil Kendall.
So I'm back, and here I'm talking about a different project that I've been engaged in over the past 5 years around the reproductive rights of women living with HIV in Latin America. So just to give you a context, the 4 countries that we've been working in here, Mexico, El Salvador, Honduras, and Nicaragua, are all countries that have concentrated HIV epidemics, so less than 1% prevalence in the general population and over 5% in certain key or most vulnerable populations, such as men having sex with men, injection drug users, in some places, males, almost everywhere, male sex workers, and in some of these countries, female sex workers. So that creates a context where there are certain social constructions around HIV that may not be as strong elsewhere, that they only affect these populations and not others in the population, certainly not generally women of reproductive age, or not recognized as being potentially people who could be living with HIV. And it also has implications in terms of operationally thinking about how one would provide reproductive health services to women living with HIV, because in this context, probably it's not feasible to expect antenatal care and family planning providers to learn about some of the specificities that are necessary in order to provide good care to women living with HIV. So we can talk about that more. Just to note that reproductive rights, of course, are internationally recognized human rights. They fall within the international human rights framework, and that there are international commitments both from the Cairo Conference to provide universal access to information and services by 2015, and the Millennium Development Goal target of providing universal access to reproductive health services by 2015. So we're inside that. Universal must include people living with HIV as well. Yet women living with HIV from around the world, Africa, Asia, Latin America, report reproductive rights abuses that range from omission of information and services to coercive sterilization and abortion. So this work comes out of a process that began in 2008, working with the international community of women living with HIV in Latin America to do policy research and advocacy around the intersection of sexual and reproductive rights and HIV. And in 2011, we decided jointly that it was necessary to document reproductive rights violations in a more systematic way, both as evidence for advocacy, but also to bring these to national human rights commissions and also in preparation for strategic litigation, if that's appropriate. And so we developed a questionnaire, piloted it, validated it in Mexico initially, and then afterwards with leaders from the 4 countries, and then it was rolled out as a community-based research project between July 2012 and February 2013. In total, 337 women living with HIV answered these questionnaires, and what I'm presenting here are preliminary results, basically descriptive statistics that are based on the effective response rate. So in terms of the distribution of the questionnaires, it's basically equally between the 4 countries. And these are some socio-demographic characteristics of the women who participated. So most were of reproductive age. Almost half were in a stable relationship at the time of the interview. Almost all of the women have children. The mean number of children were 2. 87% were taking antiretroviral treatment, and 35% live with someone else in their household who needs HIV care and treatment as well, whether that's a child or a partner. And in terms of education as a proxy for socioeconomic position, while 92% of the women were functionally literate, that is, could read and write a simple note, less than half of the women had more than a primary school education. And we also were very consciously seeking to engage with both trans women and sex workers in this project. So 13% of the responders are trans women. For questions about contraceptives, we're only asking women who have the capacity to become pregnant. 13% sex workers, 9% women identified as indigenous, and 7% as being of African descent, mostly Garifuna women from Honduras. So I'm briefly going to talk about women's perception of the quality of the reproductive health services that they receive, and then the right to information, focusing on safe conception and PMTCT, and then contraceptives and dual protection. And then I'll talk a little bit about the patterns, the prevalence and patterns that we see around coercion to sterilize. So under half of the women considered that they had received comprehensive reproductive health services, and in fact 41% said that they had been discriminated against by healthcare workers, specifically when seeking reproductive health services. And a third said that they had had negative medical or emotional health problems as a result of the lack of comprehensive reproductive health services that they receive. And this was an open, a survey that also had open response, and so I've included some of the quotes to illustrate how women feel about these services. In this case, a Honduran woman saying, the doctors just don't have times in our HIV treatment clinics, so sexual and reproductive health are not discussed in that setting. In terms of PMTCT, 66% of the women said that they had received information about prevention of mother-to-child transmission. Only 45% who had an HIV-negative partner, of those who had an HIV-negative partner, said that they had received information about how to conceive a child while reducing risks for that negative partner. In terms of a more comprehensive discussion of safe pregnancy when considering the woman's health, the child's health, and the partner's health. 43% of women said they had received information about that. And when we get into the more technical areas of using antiretrovirals for treatment as prevention, knowing that if I have a low viral load, the possibility of transmission to my partner or my child is radically reduced. The use of pre-exposure prophylaxis or home-based insemination methods. Here, only 22% of women had received any information about this in healthcare services. Yet women clearly need this information. So in this sample of women, a third had had a pregnancy since their diagnosis. And in this group of women, only 16% had talked to their providers about it before becoming pregnant. And that's something that we see internationally in the literature, that the issue of reproduction needs to be broached by healthcare providers as a routine part of care, rather than waiting for women to bring it up, because there's fear about the reactions that women get, and indeed, as this quote shows, reasonable fears. So she did bring up the issue of wanting to become pregnant with her provider, and he tried to convince her not to do so. And then she suffered censure and criticism because she went ahead and got pregnant. And as a woman leader living with HIV, that was seen very badly, that she had chosen to do that. Whereas some of us might see that as an example of her exercising her reproductive rights. In terms of pregnancy prevention, which is also very important, only 27% of women said that they had received information about contraceptives other than the condom in their HIV services, and only 25% reported receiving information about dual protection, so the use of a condom and another contraceptive method. 15% had received information about potential interactions between antiretrovirals and hormonal contraceptives, which should be part of standard counseling, I would think, for women of reproductive age and capacity, and only 10% about the possibility of using an IUD. And we see that these have negative, unintended pregnancies can have negative consequences in women's lives. So a Honduran woman says, I got pregnant because they said that women with HIV can't use contraceptives. Or a woman from Mexico who says, I got pregnant and infected with the human papillomavirus because I didn't have enough condoms. They limit us. Finally, on the issue of coercive sterilization. So not all of these women actually underwent sterilization. Some of them implemented strategies to avoid the constant pressure to become sterilized from their providers, like telling providers that they'd already been sterilized, which of course creates a problem if they don't want to become pregnant and are not receiving information about how to contracept. But in the total sample, a quarter of the women reported having been pressured or coerced to undergo sterilization. And among those women who were sterilized, you can appreciate the patterns. So here are two examples from El Salvador where the women are coerced into becoming sterilized in order to access services to prevent mother-to-child transmission of HIV. So in the first case, the nurses refusing to take her down to the operating theater for her programmed cesarean until she signs the consent forms, or the threat not to provide formula to the woman to substitute for breastfeeding. And these patterns are not specific to Latin America, as they've also been identified widely in Africa. or simply sterilization without consent. Often women don't even know that they've been sterilized until they try to get pregnant, and then someone looks in their medical record and sees that they've been sterilized. So in one case, when the woman was to be operated on for abdominal pain and was sterilized, or in the second case when she was recovering from anesthesia from the cesarean section, and they actually made her mark on the informed consent. So this is clearly, these preliminary data show that women living with HIV in these 4 countries, it seems, are not receiving the information or the services that they need to effectively exercise their reproductive rights, and that in order to protect reproductive rights as human rights and promote non-discriminatory universal access to reproductive health information and services, by 2015, states really need to implement rights-based training for HIV providers around reproductive health, and to disseminate cutting-edge knowledge about treatment as prevention, about the very low rates of vertical HIV transmission and sexual transmission, because many times providers are operating under false assumptions about the risk of transmission, which is added to already existing discrimination and stigma and produces these kinds of problems. There's also a need to integrate HIV and reproductive health services and to monitor service delivery, to sanction reproductive rights violations. In this work, we're very much focused on healthcare providers in public clinics as agents of the state, and therefore with a responsibility to protect and promote human rights. And to meaningfully involve women living with HIV in the design and monitoring and evaluation of programs related and policy related to reproductive health. And these are completely applicable to the Latin American context, but they actually come almost word for word out of the resolution made by the African Human and People's Rights Court on forced sterilization in Africa. So I think that these recommendations travel internationally. And finally, we, in our experience, have found that doing research and convening dialogues with women living with HIV policymakers and their allies has been a very effective way to create coalitions that favor and defend the reproductive rights of women living with HIV. And in the question period, I'd be happy to talk about the kind of advocacy successes that we've had there. And to thank all of the civil society partners. There were 28 civil society organizations and networks involved in this data collection, as well as the Canadian Institutes of Health Research, who support my postdoctoral fellowship, and the Ford Foundation that has been supporting this work since 2008. Thank you.
Thank you very much, Tamil. And now for our last presentation for today, we have Nina.
Good afternoon. I'm Nana Khanna with the Positive Women's Network of the United States. We are a national membership body of women living with HIV. And I'm going to be talking about reproductive justice and sexual rights for women living with HIV in a US context. And so I'm going to start just by framing the context. And I think a lot of folks already know these statistics, but I think it's just always important to start with the picture. So of course, HIV in the US really disproportionately impacts women of color. In particular, Black and African American women make up 64% of new HIV diagnoses, even though they only represent 12% of the population of women with HIV in the US. Similar types of racial disparities play out among Latino women as well. And also here in the US, poverty is a major driver of HIV infections, particularly in the heterosexual epidemic. And one of the reasons that I think it's so important to really talk about this is that somebody said earlier that I think poverty is violence is both a cause and a consequence of HIV. And I want to say that we find that poverty is also both a cause and a consequence of HIV. And here in the US, the way that policies have been set up, historically,
people have to be under a certain income level in order to qualify for essential health benefits, for medication access, for housing, for food services, childcare, nutrition. And so effectively, what's happened over the last 30 years of the epidemic is we have very effectively ended up essentially creating a biological underclass of people living with HIV who can't escape poverty, because to do so would mean risking access to essential benefits. And so we have a lot of women living with HIV who want to return to work, who are very qualified to return to work, but who just can't because they can't afford to. They can't afford to take the chance. And so, you know, I think maybe in the discussion period we might talk a little bit about how new policies such as the Affordable Care Act might change some of that. But for many women, you know, they've been out of the workforce for a long time. And so that's not necessarily a viable, and re-entering is not necessarily a viable option anymore. And so we have, this is a blog that was written by a woman living with HIV on tax day a couple of years ago called "Can I Reach for the American Dream as a Woman Living with HIV?" And here's another example of a woman living with HIV who wrote another blog. This is a woman named Kat Griffith, who's a part of our network, who talks about the feeling of being under surveillance by the Medicaid system. And the quote here is, you know, this is really talking about how this woman, this case manager or benefits administrator really has control over, over what's going to happen, and the person's in a bad mood, so what do you do? And this is, and really has control over a life or death decision around, around Kat getting access to an essential medical procedure that she needs, based on determination of her, of how much money she has in her bank account. And so, you know, so she's really talking about this feeling of being constantly watched and constantly under surveillance. And so, you know, just for a second, why is it important to understand, you know, the intersections between race and poverty and HIV? Well, I think here, particularly in the US context, reproductive justice issues for women living with HIV are also issues of racial justice. And they are also issues of an ongoing war on the poor that has been going on for a long time. And the bodies of women of color and low-income women in this country have been policed and controlled and regulated for many, many years. And that's part of a, you know, it's part of a legacy on which this country was founded. And so, and motherhood has been also, not only have the bodies and sexuality of women of color been controlled and policed and regulated, and now you put HIV on top of that. And so I just want to introduce, this is sort of alluded to earlier by Janet, I think in her presentation, the concept of intersectionality, which is really a feminist sociological theory that looks at how to study relationships between multiple systems of oppression or discrimination. And so how does this play out in terms of HIV and in terms of HIV stigma? Well, Michelle Tracy Berger, in her work, Workable Sisterhood, about 10 years ago, really looked at how race, class, and gender oppression intersect with HIV, for women living with HIV. And so you really can't separate these things, and it's not, there's not really an additive process where you can say, you know, 1 + 1 + 1 is 3. It's not like that. Race, gender, class, being a trans person, being a sex worker, being a drug user, current or former, all of these different things are part of the experiences of women living with HIV. And so the ways that, that women living with HIV are experiencing violations of reproductive rights and their sexual rights are impacted by all of these different biases and oppressions and discrimination. And so for many women living with HIV, because we come with, because we tend to come from backgrounds that are already discriminated against or oppressed or have experienced other kinds of discrimination even prior to our diagnosis, many times motherhood and partnership are the most socially valued identities that we can attain. And so this is one of the reasons why it's so important to kind of consider sexual rights and reproductive rights in a very holistic context. And for many women living with HIV, motherhood might be the only socially valued identity available to them. So, you know, we might be talking about a woman who hasn't had the opportunity to have a lot of formal education, doesn't have the opportunity to be part of a professional workforce for whatever reason, has been discriminated against in a lot of different settings. Motherhood is really her opportunity to to achieve certain kinds of status in her community, in her family structure, and in her culture. And particularly thinking about how different kinds of cultural norms play out in communities of color. So it's really important that providers understand motivations that play into decisions around conception, contraception, childbearing, and all of those things. And so one of the things that's been really striking, and I forgot to put this in here, is I think the way in which motherhood has also been used sort of as a tool to control women living with HIV and to police us. And so one specific example that comes to mind is a case that happened a few years ago in the state of Maine. A young immigrant woman who was in violation of her immigration paperwork. She had overstayed a visa, and so she was being threatened with an issue of deportation. She was about 28 years old. She was HIV positive, and she was pregnant. And so the judge in that particular case had the option to sentence her to, I think it was a 90-day sentence for being in violation of her visa, of her overstaying her visa. He chose to extend her sentence to right after her due date. And the reason that he stated was because she couldn't be trusted to be adherent to her medication if she wasn't incarcerated. And so, so it's, there are so many different kind of complicated ways in which this relationship of motherhood and sexuality and HIV are really playing out. And she was, in fact, incarcerated for longer than she should have been, but then I think with a lot of advocacy and litigation was released before that date. So a couple of years ago, we did a survey on human rights, looking at human rights issues for women living with HIV in the US. And we released a report, and I'm just going to talk a little bit about that report, but focus more on a more recent one we did. Some of the findings parallel what we heard earlier. A lot of stories around coerced abortion, a lot of stuff around trauma, a lot of women reporting that they had been coerced into sterilization, had been encouraged to abort, had been discouraged from getting pregnant, and a few people talking about sort of this dual trauma of being of finding out you're pregnant, finding out you're HIV positive at the same time, being coerced to have an abortion, and not having anywhere to go for mental health services to deal with that sort of dual trauma of losing your child, and for many women, sort of losing their something that had been so meaningful to them, this opportunity to parent. Losing that at the same time as getting an HIV diagnosis, and that we really don't have services for women who are in that situation. There are no specific services for that. So based on some of those findings, we decided to do another research project. And so last year, PWN USA took on a research project to look specifically at sexual and reproductive health and rights for women with HIV here in the US. And we did, the study that we did was conducted entirely by women living with HIV. And so we had a core team of 4 women with HIV who kind of defined the research questions, designed the study, and then conducted a policy scan, a literature review, and a survey, which we administered, and also wrote and edited a report, which was released in November of last year. And in addition to that, we had 8 advisors who were also women living with HIV from different parts of the country who served in an advisory capacity to help with disseminating the survey, interpreting results, help to pilot the survey, and take it a few times. And so there were about, in total, there were about 12 women living with HIV involved in this whole process. This says 6 advisory team members. There were 6 formal advisors, but there were 2 other women with HIV who sort of advised on the full report production. And so, one of the things we were able to do through this process is also provide economic opportunities to all of the women who were involved. They all served as paid consultants. And so the data that we collected fell into these 8 or 9 areas. So demographics, HIV status, engagement and care, relationships, including intimate partner violence. We looked at body image perceptions and self-esteem. We looked at changes to sexual practices following diagnosis, including disclosure. We looked at decision-making around sexual health and reproduction. And we also looked at access to SRH services and healthcare, as well as any violations of confidentiality that had occurred. And a lot of the questions in our survey, it was about a 70-question survey, a lot of the questions were designed to kind of fill in gaps in what we noticed we couldn't find in the literature review. Because there was very sparse literature from the US in the last 10 years about body image, sexual stigma, reproductive decision-making, and partnership for women with HIV. And so we ended up having 179 women take the survey. We administered it in 2 ways. I'm sorry that I'm losing my voice. I've been kind of losing my voice for a few days. We administered it in 2 ways, online and on paper. About 3/4 of the respondents took the survey online, and just over a quarter took it on paper. And so the methodology that we used, it was sent out through a SurveyMonkey. We had a lot of questions that would exclude people who didn't fit the criteria. And then for the paper version is what we really counted on our advisory team to help kind of implement that. A lot of the women who took it had a different literacy level and different technology access than the women who took the online version. And I'll talk a little bit about how the results parsed out differently later. 41% of our online respondents and 43% of our paper respondents were currently of reproductive age. A lot of them, the majority had been of reproductive age at the time they were diagnosed, but many have been living with HIV for 10 years or more. And the age range was 22 to 65. 98% of our respondents were identified as women and as female, and 2% identified as transgender, male to female. And this just shows some of the sexual orientation data. And geographically, we were able to get actually very good representation from the southern US, which is really disproportionately impacted when it comes to women with HIV. In terms of socioeconomic indicators, 30% of our respondents lived in subsidized housing. 47% were earning under $20,000 a year, and 29% were under $10,000 a year. So this data is different from the HCSS study, the HIV Cost, Services, and Utilization study, which was conducted actually in the 90s. But the data is still being released because it seems to be the only kind of nationally representative sample we have of people with HIV in care. And they keep releasing data from it, even though it's very old now. So that study showed that 64% of women living with HIV were earning under $10,000 a year, reported incomes of less than $10,000 a year, compared with 41% of men living with HIV. And so our sample, partly because we did so much of it online, does not reflect accurately, I think, the US epidemic among women living with HIV. So I think that's something that's important to keep in mind, is that the women that we reached were more likely to be in care, more likely to have a lot more information, more likely to have a lot more access and a lot more resources than the typical woman living with HIV in the US. Over half of them were working or volunteering part-time or full-time. But most of them were not being paid for their work, or a lot of them were doing work in the parallel economy to support themselves. So catering, making jewelry, doing lots of other kinds of things that wouldn't affect their access to the AIDS Drugs Assistance Program or other kinds of Medicaid and Medicare income that they were dependent on a monthly basis. Over half had a child under 18 in the home, even though less than half were of reproductive age. So a lot of them were grandparents, and a lot of them had other kinds of childcare responsibilities for other people in their family. This is the breakdown of race and ethnicity from our respondents compared with the CDC's, what the CDC says about the demographics among women living with HIV in the US in 2010. And so you'll see that our demographics, again, don't exactly match, but they're pretty close in some of the categories. We were able to get pretty close among women of African descent. We were much lower among Latina women, but we did a better job on the paper surveys with Latina women. This is something that I thought was really interesting. This is our engagement and care cascade. And so folks who are familiar with the care cascade, it's basically looking at kind of across from percentage diagnosed to percentage linked to care, retained in care, and then on ART and virally suppressed. And so Our engagement and care cascade was really different from the National Engagement and Care Cascade, and I think it also shows that our sample is a really different sample of women. So 96% of our women were in care. This was self-report, but a lot of their responses indicated that they were in care. 91% of them were on antiretrovirals, and 80% of them had a suppressed viral load. And that's compared with, only about a quarter of women living with HIV in the US have a suppressed viral load. The biggest drop-off among women living with HIV in the US is from linkage to retention. So we're able to link about 71%, and we're only about to retain about 40% of women with HIV here in the US. And we think that that some of the factors around sexual silencing, reproductive rights violations, trauma, violence, and rates of post-traumatic stress disorder, which are about 6 times as high among women living with HIV in the US as they are among the general population, are part of the reason for that. And so I think one of the interesting questions here, and I think somebody talked earlier about the role of advocacy networks and social support networks and the importance of those. I think it was Florence talked a little bit about that earlier. And we really find that to be true. We have done a little bit of kind of qualitative research that basically tells us that as women are more involved in leadership and advocacy and more involved in networks of women living with HIV, they are more likely to be involved in their own care as well. And so this was a very different sample from the national average. And we found that over half, although 96% of our sample was in care, over half of them who were in care had not been counseled about treatment as prevention. So while a lot of them knew about the results of HPTN 052, they knew, sort of vaguely, they had heard that, they agreed with the statement that that viral suppression could reduce the risk of onward transmission of the virus. A lot of them agreed with that statement, but over half of them told us that no provider had ever told them this. And this is the exact question we asked. Has any provider, a doctor, nurse, case manager, or peer advocate, for example, ever told you that when your viral load is undetectable, you're less likely to pass HIV on to an HIV-negative sexual partner? That purple is the no. I'm sorry, the red part is the no. So, and the yellow part is the I don't remember. So a bunch of them were sure that they hadn't been told, and some of them weren't sure if they had been. Sorry, the yellow is I don't remember.
The big one. That big one.
So this is we consider this to be a huge reproductive rights violation. The information is out there. This has enormous implications for women's rights to natural conception, to think about their sexuality, in a whole different way, to think about reproductive options and reproductive choices in a whole different way. And the fact that, almost 3 years after the results of 052 have been out, and we have this really great data, that the information has not percolated out into the community, and providers are not sharing this information with their clients and their patients, we think is very reflective of a huge sexual stigmatizing of people living with HIV, and particularly women living with HIV. Because just anecdotally, if you look at if you follow sort of the email threads or the blogs or the online forums and things like that, there's a huge conversation happening in the MSM community about zero sorting, and providers openly acknowledge that as a prevention strategy, and but nobody's really talking to women about the fact that if their viral loads are suppressed, they're less likely to transmit. So we also asked them, one of the reasons this is so important is because we found that they're getting their information about sexual and reproductive health, they're very much reliant in that from their HIV specialists. And so if they're not getting this information from their HIV specialists, where are they getting it from? Our online respondents told us that 3/4 of them really count on their HIV specialists for sexual and reproductive health information. And our online respondents also told us that the internet is a major source of information for them, which was obviously very different from our paper respondents. 83% of our respondents had not been to a family planning clinic since their diagnosis, and 51% said no provider had talked to them about being sexually healthy, about sexual health. We also found that, so there is a real lack of data around sort of partnership of women living with HIV and the state of partnership here in the US. And so we asked some questions about partnership. 59% described themselves as being in a relationship. 64% said that their partners were HIV negative. We asked about relationship satisfaction. Over half were very satisfied, and they were very satisfied with the quality of friendship. In their relationship, almost half said that they were dissatisfied, and most of them cited financial responsibility or financial dependency as a factor that influenced that. And just another thing that hasn't really been explored is the ways in which a lot of times women living with HIV have access to a set of resources that their male partners don't. And their male partners may be currently or formerly incarcerated, maybe can't get jobs for whatever reason, because for a whole variety of reasons that are structural and often racist. And so what ends up happening is that a lot of times women are providing food, are providing housing, and are providing a whole range of other things for their male partners, and it creates a very interesting kind of constellation of relationships and violence and sexuality issues. And so we also looked at body image and self-esteem, and this is some of the internalized stigma stuff, I think, coming up, and this is no surprise, but we heard that there's that a lot of women have negative body image, have negative self-esteem, and that this is impacting their ability to engage in and enjoy sex. And that it's linked with social isolation, depression, and partnership choices. And so these are just a few quotes from some of the women that we talked to. We also found that rates of violence and past trauma were very high. So almost 70% had been sexually assaulted. Over a third had been sexually assaulted for the first time before the age of 13. Many of them have been sexually assaulted again and again and again after that. And almost 3/4 were survivors of intimate partner violence or domestic violence. So we also, this is just some data from another study that was done looking at provider-patient communication that basically sort of parallels a lot of what we found. The bottom line here is that only about 20% of women with HIV in this study who wanted to talk to their providers about pregnancy were able to have the type of conversation that was really kind of meeting their needs and meeting their goals. And then I wanted to also put this in context. So we heard a lot about issues around criminalization and criminalization of HIV and how that kind of factors into sexual stigmatizing. So over 30 states and US territories have some kind of law in the books that criminalizes HIV exposure, non-disclosure, transmission, or allows for sentence enhancements in some way. And criminalization laws create a context and an environment in which women can be easily threatened, coerced. Their HIV status can be used as a tool of coercion and abuse, in our own homes. And so this is really a big problem in terms of women being able to fully live and realize our sexual and reproductive rights. So I'll just end with a handful of recommendations. And the document that we produced is like 80 pages long, so this is a very abbreviated version. But just a few recommendations. Research and counseling on the sexual activity of women living with HIV should go beyond just risk behavior and sort of a focus on, this like myopic focus on condom use and how frequently you use condoms, to include overall a non-judgmental and affirming attitude towards the sexuality of women living with HIV. Women living with HIV as sexual beings have the right to not only have sex for the purposes of reproduction, but just to have sex because it's fun and because we have the right to enjoy it. And to understand that sexual activity and intimacy are important quality of life issues for women living with HIV, and that body image and self-perception and all of that plays into this. And that sexual and reproductive health and rights really need to be investigated throughout the lifespan. One of the things that we found in the literature review that was really disturbing is that there was very little data on, there was very little information on people, young women who had been born with HIV, who are now adults or adolescents, and their sexual and reproductive health care needs. There's also very little data on sexuality and reproductive and sexual and reproductive health issues for women who are past reproductive age, because it's kind of like it doesn't really matter anymore if we can't vertically transmit. Who cares? Well, we care. So we think that needs to be studied. And advocacy is urgently needed to repeal HIV-specific criminalization laws, to ensure access to fertility treatment for people living with and affected by HIV, and to support adoption services, custody rights, and all of those things. So I just want to end with thanking our core team and our advisory team, and most of all, the women who took our survey, made the time to take our survey and share their intimate results with us. Thank you.
Thank you very much, Nana. So we have about 30 minutes for Q&A, but I just wanted to offer a comment before we move into Q&A. One of the things I felt I heard quite a bit from all our panelists today was just the fear in the women's voices, whether it be from Sub-Saharan Africa, whether it be from Mesoamerica, or even within the United States. And that was fear of providers. It was further compounded by the overstressed health system. And there also seemed to be a strong correlation with health-seeking behavior, both current and future. So, as Mary mentioned in her talk, she mentioned the universal health coverage and how to consider disrespect and abuse when pushing on universal health coverage, and also here in the U.S. with the ACA. I'd like to hear from our panelists how they think what we've talked about today is going to affect these policies. But as I let you think on that for a second, I'm wondering if we can take some questions from the audience.
Hi, Jill Gay, What Works Association. One comment, one question. The comment is to correlate gender equality with improved maternal health care. And I think it's past due. And I think, we've done this for a long time in the field of HIV, but it's lacking in the field of maternal health, and yet we know it's so critically important. So that's a brief comment. My question for the panelists, not so much for Nana, but for other countries, is there's a lot of debate about the role of men in maternal health care. And some studies show that, in fact, if you don't involve men, the outcomes are better. And some show that if you involve men, the outcomes are better. And where do you think we should go with this?
Thank you. Here.
My name is Embry Howell, and I work at the Urban Institute here in Washington. I have a particular concern about patient protection, human subjects protection. It came up only kind of peripherally, and I have a personal interest in this because I'll be presenting a seminar at the African Evaluation Association about human subjects protection in an African context. So since we're full of researchers in the room, and many of you have done studies there, I'd be interested in your comments, and then also, if you wouldn't mind sharing a business card or your email address, I'd like to contact you later to discuss these issues with you.
Okay. We have one way in the back.
Hi, Millie Kayongo. Thank you so much for the panelists. My question is for Janet, and talking about the issues around stigma and how they affect use of ANC or perhaps PMTCT and other HIV-related services. I was wondering whether you were able to explore how the issues that are affecting uptake of services have to do more with the broader maternal health issues primarily. Because as you know, as we're just all getting back from that meeting on SMGL last week, and you did see improvements in maternal health platforms actually help even HIV positive women increase their accesses to care. As countries move away from towards option B+, several of the issues you had in your cascade will actually not be particularly relevant. And so I'm wondering whether your research has explored some of that.
Hello.
So that's 3 questions. But we'll start there. Okay, so first I'd like to hear back from our panel on my initial question of the role of rights-based healthcare in universal health coverage and also the ACA. Anyone like to start?
I guess I'll start small with the ACA, and then other people can cover the rest of the planet. So, I mean, in terms of ACA implementation, I think there are a lot of opportunities, but there are a lot of cautions as well. And so, one of the cautions is that while we're expanding coverage for a lot of people, we're also potentially reducing a large. We're also potentially diluting people into pools of non-specialty providers and networks that are not as prepared and equipped to take care of people with HIV because they don't have the kind of specialty information about, especially when it comes to stigma or other kind of intersecting oppressions that we talked about earlier. So do they have cultural competency around working with sex workers, working with people with mental health issues, working with people who are active substance users, working with LGBT folks? So those, I think that's a range of questions, and there's going to need to be a whole lot of training of providers as people are moving into FQHCs, community health centers, out of Ryan White funded facilities. I think, secondly, though, I think that there are a lot of opportunities for integration and for better coverage overall. So the recommendations around women's health preventative services, for example, as well as the recommendations that came out recently from the White House Working Group on HIV violence against women and gender-related health disparities, offer us a lot of opportunities to increase, for example, screening for domestic violence and intimate partner violence in HIV settings, and vice versa, screening for HIV in DV settings and intimate partner violence settings. And so, and then, of course, there are some really great recommendations around mammograms and sexual and reproductive health care services. And so, so I think that it's a little bit of both. And what will be really important is ongoing monitoring, including community-based monitoring of and engagement of people living with HIV about how these transitions are really working.
I'm going to echo some of Nana's comments, and I'm going to speak about universal health care in. Can you hear me? Okay, thank you. So I'm going to attempt to answer the question about universal health care, speaking about the context that I actually know the best, which is Mexico, which of course achieved universal health coverage in July 2012 with the popular health insurance. And I lived in Mexico during the whole time that the insurance was designed and rolled out. And a very important part of this insurance was access to a catastrophic spending fund to stop impoverishment of people with very expensive diseases, including HIV. And so this was the mechanism by which Mexico scaled up antiretroviral treatment, and you now have 90% coverage in that country. But there are serious concerns about quality, particularly, and I've raised some of the issues about quality for integration, but particularly in the maternal health field. In the last assessment of maternal mortality that was carried out, so this would be 2011 data, we know that 8 out of 10 of the women who died were affiliated with some kind of health insurance. And we know that 9 out of 10 attended a facility before their death. And I don't believe that without addressing and taking a rights-based perspective, which includes quality, technical quality of care is rolled into that rights-based perspective. It's not only intrapersonal. We're not going to create the conditions to prevent maternal deaths. So women need to be able, we need to avoid the 3 delays as Mary laid out, but and I don't believe that's going to be happening without moving forward on rights. And therefore, for women to be empowered, communities have to be empowered, and there needs to be accountability at the local level. So that's why the focus in this document, in some parts, on community mobilization and support for pregnant and postpartum women.
So, okay, just to also echo points that Tamil and Nana have also mentioned. When we look at universal health coverage, if I can speak in maternal and child health, for instance, in Tanzania, our policy is all pregnant women and children under 5, as long as they receive services from a public health facility, they receive it for free. But it's at the end of the day, as Tamil alluded to, what is the quality of care that they receive? And the majority of the population can only afford that free care. And so the quality is what they receive, is what they get. But when we look at that, we need to ensure that moving ahead, people do understand what are their rights. Because if at the end of the day, the demand is not created from the end receivers, who are the women, and children receiving this care, then it might be even harder to ensure that we push our system to increase funding in healthcare, to improve the services, to improve the constrained health systems and human resources for health. If I take for an example, generally at the moment, if a child dies, a newborn dies, it would usually be considered by a family, the child wasn't meant to survive. That really needs to be unacceptable. Even at the moment at our national hospital, you would see kids coming out, being wrapped up in a traditional cloth, and they're going to be buried. And it's like, that's it. It wasn't meant to be. This child wasn't meant to live. So we need to get out of that box and say, this is unacceptable. At the end of the day, if a woman if she's being referred and an ambulance has to wait for other emergency cases, and then complicates further the outcomes of this woman and her baby. So I look at that, and I think it all needs to be tied down to, we need to create the demand for people to be able to understand that they need to receive better services, to stimulate that from bottom down and bottom up and top down. Just an addition.
Well, I think I was going to save my breath to answer some of the other questions, but should I go ahead for some of those, or how do you want to do that?
We can move on.
Okay.
If you'd like to, unless you want to go, if you have a strong opinion about it, please.
No. I just wanted to address some of the other questions. I mean, I also believe that that the lack of gender equality and unequal gender norms are kind of at the root of all of this, and particularly the worse outcomes and service utilization behavior for women is really at the root of that. The role of men and partners is a complex one, obviously, and it's in the work that we've done with women living with HIV and other pregnant women in Kenya. Most women seem to desire the involvement and support of their male partner in these issues. There are some partners who are just too violent and too dangerous, but we also have done a lot of work with men who also want to be more involved in pregnancy and childbirth and having, a healthy family. So it seems, to try to, but it's just been such a challenge to figure out the way to involve men. And at least in the Kenyan setting, we're there's been a real struggle to get men to come into clinics and into antenatal care or come to delivery. It's not culturally acceptable. It's not male friendly. And from time to time there are campaigns, and the men come and get the T-shirts, and then when the T-shirts run out, they stop coming. And so, that's why we're kind of moving toward home and community-based approaches, and just although that's going to have its challenges as well, but I think we just have to keep looking for the ways, and I think to reach men where they live, where they work, and trying to promote these more gender equitable relationships ultimately is going to be the answer, but it's going to be a struggle. Maybe I'll let others comment on that issue before I say anything else, if others have
Would anyone
comments
else
on
like to
that.
mention
The men.
the role of men?
So I think just specifically focusing on now that we've moved into option B plus, I think from what we've experienced in our clinics, women having been enrolled, high uptake of antenatal clinic and high uptake of HIV counseling and testing, and adherence to the short-term prophylaxis, which has now moved into a long-term, lifelong treatment for the woman. I think the most encouraging thing for the mother, as she has kept this secret of being HIV positive all along, is that there will be an end to her taking this medication. So now when we look at that she needs to take them for life, and she did that transiently, knowing I can keep a secret for, if I, by the time she's enrolled at antenatal clinic, she's 20 weeks, on average, so she can keep her promise for another 20 weeks. By the time she delivers, for another few weeks or so, depending on the stages of the guidelines, she's safe. And now when we look into lifelong treatment, we definitely need to include these partners, because how can she explain that she needs to take these pills herself and her baby, as long as the child is breastfeeding? In Tanzania, 98% of children breastfeed on average for 21 months. If this woman has to keep giving her child antiretroviral, how can she keep that a secret? So I think the role of men, again, as Janet said, has its own complexities, but I think we need to just look for ways to make sure that men are involved, be it going out into the community, empowering men. I think someone mentioned the project in Kenya where they're trying to do the fathers to fathers.
Mentor
We just
fathers,
need to look for all these mechanisms to have the men on board, I think, specifically for the PMGCT.
And just to add to that, also addressing men's sexual and reproductive health for, in, and of itself. And making men's health also an important objective to be looked at, I think, is a way. And going beyond only looking at involving partners in HIV testing. The literature is very scarce on interventions that go beyond trying to get men to test for HIV. So we need more creative and more comprehensive ways to engage with men.
Thank you. Does anyone want to comment on patient protection, in Africa? Or is that something that someone would be willing to talk to our person after the?
I mean, so you're talking about human subjects in research, and I can say something briefly, and we can also definitely talk later. I mean, we have to be really careful, I think, when we're involving women and pregnant women living with HIV in research studies. And, we use a very kind of a comprehensive informed consent procedure that involves not just, reading a form, but really trying to explain and to have a dialogue to make sure people are actually understanding what you're talking about. So that's a really important aspect of it. We also, make sure to compensate people for the time that they're giving to us, but not a level that would be considered coercive. I mean, there are a lot of issues involved, I would say. But another issue is safety of of women, because sometimes that signed informed consent form could be the only thing that sort of might actually cause unwanted disclosure of her HIV status to her partner in the community. So making sure that women don't necessarily, you don't force them to take a copy with them if they don't want to, and making sure that everything protects their safety is of paramount importance.
Thank you. And would you like to finish up with the question directed to you, Janet, about PMTCT and maternal and the platform for maternal health?
Yeah, that was a very nice question, maybe a difficult one, but I just what we actually found, which was I think was fascinating in this Nyanza province, very high HIV prevalence setting, was that stigmatizing and discriminatory attitudes related to HIV seem to be negatively related to delivering your baby in a health facility for all women, not just for HIV positive women. And the qualitative work that we found when we talked to people in communities, that people had been, there were all these campaigns out there. HIV positive women deliver in a health facility, you can have an HIV-free baby. All women infected with HIV should deliver in a health facility. And so there's always been this kind of conception that health facility birth is for women with problems, right? And then this had been kind of now extended, that people saw, oh, she's delivering her baby in a health facility. She probably has HIV. And it just becomes one of the factors that are kind of tipping against health facility birth. But we did see these kind of effects for all women. And another interesting finding is that when we did a previous study looking at observing labor and delivery services in hospitals, we found that the women who suffered the most stigma and discrimination were women of unknown HIV status. So the ones who either refused to test or weren't tested for some reason, the health workers felt very uncomfortable and often were testing those women without consent and doing things like that. So I think these issues are broader than just HIV-infected women, and I think they can have effects on maternal health in general. So those were my thoughts, but I don't know if that exactly addresses the questions, but we can talk further.
Okay, we have a very adamant question right in the back there.
It's not a question,
Comment.
more of a comment, which I think Janet has just mentioned. And I just wanted to, again, just emphasize that many of the things that have been raised are raised in the context of HIV, about the abuse and disrespect for women. But on the overall, they apply to the services rendered to women out there, irrespective of the HIV status. And I just wanted to ask the researchers to please, when they do research, to also include the HIV negative group. The reason these voices seem like they're coming from HIV positive women who are targeted is because an HIV positive people have a group, they have a voice, they are a group. There is no support, there is no group for HIV negative women. So if we were to sit in a room of women who have experienced labor and delivery or services in most of these areas of HIV positive women, you would think that actually it's targeted at them. But if we were to include the negatives, you would find that this is across the board. The services are just generally poor. So we've got to increase the ethics, the awareness about human rights and the abuses that is out there and how to reverse it. It's not necessarily aimed at HIV positive women. Yes, it is increased in certain areas, but overall, if we were to include the negative group, it's just that they don't have a voice. They are not a society, they are not a community, they are not a group.
Mm-hmm.
Yeah, that's a good point.
Thank you for that. Can we take a question up here, and then I think we'll need to move on to the final answers by our panel, since we're running out of time.
Moving forward, after seeing that stigma indexes are a threat universally, I was just thinking on PMTCT and the neglected brackets of the negative women. How can we do our projects? How can we get into at policy levels and the community-based programming on how to put the negative woman who is breastfeeding, a negative, when we talk of negative, is negative at the time when, at the antenatal time care. Usually, because of stigma, going back for HIV testing is a problem. So how do we design our products? This is just a food of thought for all of us here. How do we design our projects to have them in our projects throughout until when she stops breastfeeding? Because there's data showing that the woman is HIV negative at some point, and then at a later stage, the kid is positive, without the mother knowing that she's positive.
Yeah. Yeah, well, I mean, this is actually an extremely important point, and that one that I've been trying to focus on is the issue of repeat HIV testing during late pregnancy and labor and delivery, because as you're saying, what happens, a woman comes in, she has her first ANC visit, she is negative. Well, it's like she's got, she may think she's scot-free, her partner may even, kind of testing by proxy, oh, my wife's negative, I'm probably negative too. But the fact is that there's a continuing and high risk of HIV acquisition during pregnancy, and it's been shown to be higher than in other groups of women. And as more and more women get tested at their first ANC visit, the proportion of maternal to child health, mother to I've been talking too much, obviously. The proportion of infant infections, more of them are going to be coming from this group of women who actually seroconvert later in pregnancy, and they're really being missed. Recently in Nyanza, we saw that it's like less than 10% of women who would be eligible for retesting and later actually get tested again. And so what we're doing in our intervention study is that we're including both HIV positive and HIV negative pregnant women and partners, I think, and we're doing what we're planning are home visits that center on issues of pregnancy health, safe delivery, breastfeeding, and all those issues, but we're also including an offer of couples HIV counseling and testing with facilitated disclosure. And even if we already know the woman is positive from the clinic, she's probably going to prefer to be retested with her partner again and have a mutual process. So, but this kind of strategy puts equal kind of emphasis on both negative and positive women, and it makes it more acceptable in the community as well, instead of just visiting the homes of positive women. So that's one strategy that we are testing out. We'll let you know how it goes.
Anyone else want to comment on that?
Well, it's kind of a response to both Hannah's comment and Carol's question, is that really I do this work because we're aspiring to the best sexual and reproductive health for all women. And in some ways, I think that if women living with HIV who face multiple forms of social disadvantage and discrimination, but are organized and vocal in many places, if high quality services can be delivered to them, then we should see an effect of lifting the quality of all services, right? So, and in our own work, one of the strategies that we've taken, I think these are context dependent, but is to work with the broader women's health movement that's focused on reproductive health to try to get them to recognize HIV as a women's issue and as a reproductive health issue for women. So that will probably vary by settings, but I think that we need to work in coalitions and advocate for better quality services for all women, because I recognize that what Hannah is saying is true. Often service quality is just poor for everyone.
Yeah.
Thank you, Tamil. I'm sorry to say I think that we are done for our time today. Thank you all for coming today. I believe our panelists will stay after if there's any questions, that if you'd like to follow up with them directly. But thank you very much again for coming to our panel this afternoon.